So it's very small print, but it's just an overview of what I'm going to cover. You need to see this. So in terms of dialysis, I'm ashamed to say that we are actually the largest hemodialysis recommenders in the world, and a lot of it had to do with financial reasons. Doctors being the owners of dialysis units, as a conflict of interest, and during that recommending dialysis. But it also has to do with the fact that the training programs in the United States, they lack a lot of content into peritoneal dialysis education. If you take a look, this is the prevalence of end-stage renal disease. We're only surpassed by two countries, Taiwan and Japan, and the reason being some nephropathies are very common in Asian people, like IgA nephropathy, but most of the kidney disease in the United States come from lifestyles. It comes from diabetes and hypertension. If you guys remember, diabetes is the #1 cause of kidney failure. The second one is hypertension. The third one, you start seeing things like medication-induced nephrotoxicities, glomerulonephritis, and so on and so forth. But for the most part, it's hypertension by 50%, diabetes by 50%, and about hypertension is about 30%. The U.S. is top of the list, and this data comes from the United States Renal Data System, which is a governmental database from North America, from the U.S. and Canada, and they have this actually is a website, free access if you're curious to know about prevalence and incidence and more details about kidney disease. So when I look at the percent distribution by modality, it's very sad to hear that the U.S. is one of the top countries on hemo, and the rest of the world, if you go down, most countries, they adopt peritoneal dialysis, which is much cheaper, and it also has some benefits. Somebody was asking me yesterday, why hemo versus PD, and that's a decision that is usually made by the patient, but it's an educated decision. It's not something that probably is imposed on a patient. So generally speaking, we're responsible for educating our patients about the pros and cons of doing one modality or the other. The benefits of doing peritoneal dialysis is the fact that you still can be productive. You can still have a full-time job because the dialysis happens at night. Typically, I don't know if you guys ever seen a patient on peritoneal dialysis, but they have a catheter that goes into the peritoneal cavity, and that catheter is connected to a cycler machine that we hand the dialysis solutions, and we infuse that solution. The machine infuses the solution and lets it dwell for a number of hours. It depends on the prescription, and that solution creates a gradient, and that gradient basically pulls fluid and pulls solute and pulls the toxins, urea and all the other uremic toxins. That's how typically patients get their dialysis by doing these exchanges. So we usually advise patients to think about the options for young people, smart people, socially stable people. Peritoneal dialysis is a great option. You have to remember that in most countries, this is the modality of choice because it's cheaper. And the other benefit that I see is that it entitles patients to do something for their health. Dialysis patients, they pretty much give up. A lot of them. I'm not saying all of them, but a lot of them give up. They just show up and they're waiting. They're waiting for something to happen. Do you guys know roughly what is the life expectancy of a diabetic on dialysis? You guys know? 10 years. About 10 years. 70 to 80% of the patients are dead by year 10. And those numbers, fortunately, are improving because we have better techniques, and it varies a lot. When you look at the data, if you concentrate in metropolitan cities, the outcomes are better than when you look into the southeast and areas of increased poverty. Those patients, they usually have less favorable outcome, and a lot of it had to do with the fact that they develop a lot of access-related complications. Excuse me. Access-related complications, like you guys know. Before I move forward. Do you guys know how we deliver dialysis? Do you know the different axes that we have? Have you ever seen a patient with a fistula? Okay, so the fistula is the desired method of like delivering dialysis, but some patients, they don't have enough vasculature, or they have a complex anatomy or pretty severe vascular disease, and they end up requiring a graft. A graft is pretty much a piece of plastic that the vascular surgeon connects to be able to facilitate the needle cannulation. But some patients don't have any access at all, and they end up getting those catheters. And I don't know if you've ever seen a dialysis catheter. Have you guys seen patients with dialysis catheters? So those catheters, they, number one, teaching point, you're going to go home knowing and understanding that those catheters are not good. If your patient shows up with a catheter, it's because, number one, it's probably a patient that doesn't have insurance, and a lot of these medical patients are turned down by vascular surgeons because they don't pay them anything for creating the axis. So they live with a catheter in the central vein, and they walk around with that catheter, and those catheters are associated with significant complications. Do you guys know some of the complications? Infection is probably the most important one, and the infection can range from an exit site infection, from a tunnel infection, like there are 3 different types of infections. The exit site, when you see a little bit of erythema and a little bit of pus coming out. Then a more severe degree of infection is a tunnel infection, meaning that the bacteria is already traveling through the tunnel tract. And the more severe spectrum is bacteremia, catheter-related bacteremia. And bacteremia can carry significant consequences for patients because they can either have metastatic sites of infection, like bacterial endocarditis. I'm sure you've heard about bacterial endocarditis in IV drug users. Or they can they can also develop things like discitis or an epidural abscess, and people can become paraplegic from. I've seen 2 patients in my career becoming paraplegic from catheter-related infections that were not taken care of. You need to move very fast. For those patients, they need neurosurgical consultation and things like that. Okay, so going back to dialysis, most patients in the U.S., they are on hemodialysis. We're trying to change those trends because we're trying to motivate more students and more residents and more fellows to educate patients about options instead of like telling them, you have kidney disease, you're going to end up on dialysis. But we try to tell them, these are the options: peritoneal dialysis or hemodialysis. And for my patients, I even encourage them to do home hemodialysis, but you have to have a little more sophistication to be able to do home hemo, because you're pretty much doing everything on your own. And you need to have a treatment partner, whereas the hemodialysis patient or the peritoneal dialysis patient, you can still do it on your own, even if you don't have a treatment partner. But for home hemo, you need to have well-established vascular access, and you need to have a treatment partner. So those patients are a little more sophisticated. I have 2 patients on home hemo, and they're pretty sophisticated people. One of them is a retired pediatrician, and he pretty much goes everywhere. He goes on cruises. Last time he was in the Mediterranean, it's like he did like a 2-week cruise. He carries the machine with him everywhere he goes, and he does dialysis himself, and he enjoys it from an excellent quality of life. Yet being a dialysis patient, but the peritoneal dialysis patient usually benefits from doing it because they can be productive and they can travel. The size of the cycler is probably the size of the printer. It's probably this height. It's just the size of the printer. There's a special suitcase. They put it in. They take it with them. They cannot get charged in the airlines because it's life-sustaining equipment. That's another benefit when the patients have that, to be able to get a discount on your electricity and your water bill because you have life-sustaining equipment at home. These patients can enjoy Freedom Baxter, which is the manufacturer of these solutions, the peritoneal solutions. They ship the solutions everywhere you go within continental U.S. Unfortunately, they don't ship to Hawaii or overseas. But if you end up going overseas, you pay a fee, and they can deliver the solution. So a lot of the PD patients are very young, active people, and they travel a lot. So that's how I sell it to them. Obviously, every modality has some pros and cons, and every modality can carry significant side effects when it comes down to access-related issues or hemodynamic issues. We're going to try to review some of these things today. But the bottom line is that for you guys is that you need to understand that there are different types of renal replacement modalities. And for the outpatient world, we have hemodialysis, we have home hemodialysis, we have nocturnal hemodialysis. These patients, they go and they sleep in a dialysis unit and they get dialyzed. And those patients enjoy from excellent blood pressure control, excellent phosphorus control, and excellent electrolyte control because they're getting more dialysis. Sometimes we even have to replete phosphorus on these patients. It's crazy the amount of clearance that they get. And we have peritoneal dialysis. In peritoneal dialysis, it can be done either with manual exchanges. You know, we train the patients to learn how to do the manual technique because you never know. There's a natural disaster, there is a power outage or conflict. Who knows? They need to know how to do the exchanges. And then when they're very, very well savvy and trained, then we move to the cycler. And the cycler is usually done at night when the patient's sleeping. And again, it sounds like kind of weird that you're sleeping connected to this machine, but the machine does everything, and the patient, they have to worry about it a little. Okay, so those are the modalities. In the hospital, we have other modalities of dialysis. I'm sure you heard about CRT, or you've seen patients on CRT, very sick patients in the ICU. Those are continuous modality of replacement therapy, but we don't have such a thing in the outpatient setting. We only use that in the ICU setting. Okay, so the cost of end-stage renal disease is tremendous. If you take a look at it, it's basically from the a lot of the chunk it comes from Medicare money, and why? Because dialysis patients, they usually become disabled, or they're entitled to become disabled by law. Although I try to tell my patients not to go on disability because mentally they do very, very bad if they like if you have a young, healthy, energetic person that you know could be working and you let them go on disability, those patients usually start like not taking care of themselves, and it's always good to work. That's how I tell it to patients. It's always good, you need to help yourself and you need to remain in the workforce because these patients become very depressed. I'm sure you've heard about like dialysis patients are crazy. Have you heard about that? Like all dialysis patients are crazy. That's actually not true, but there is some truth to that, and it's the fact that non-compliant patients are likely to end up on dialysis. Whereas if you take care of your diabetes and your hypertension, you're unlikely to end up on dialysis. So we end up picking up a lot of these problematic patients in the dialysis units because they weren't good listeners when they in the early stages of their disease processes, and you don't expect they're going to become good listeners when they become dialysis dependent. So a lot of the times we hear like, oh, dialysis patients are crazy, but there's an increasing sense of depression. And you can probably imagine if any of you guys have to go on dialysis, I think that's pretty, a lot of patients end up developing an adjustment disorder or things like that. But this graph shows the cost of hemodialysis compared to peritoneal dialysis. So it's amazing how different. Like look at this little bar, it shows peritoneal dialysis. All of these expenses from hemo, and that's a trend that we're responsible to change. We new generation of internal medicine nephrologists, we have to educate the patients because it's good from the patient perspective and it's good from the societal perspective if we enroll more patients on peritoneal dialysis. And then this is the cost of transplant. That's why you always hear that it's more cost effective to transplant patients rather than to keep them on dialysis forever. You guys heard about UCLA Harbor, right? UCLA Harbor. So it's one of the residency programs. It's the only county hospital transplanting illegal or undocumented. I shouldn't call it illegal. That's a bad term. Undocumented residents, they get transplants, and from the last year, I believe they did about 3,000 transplants or 4,000 transplants in the state of California, and about 200 of those cases were given to undocumented residents that otherwise would have never gotten a transplant. And that only happens in California and a few other states. I don't know the name of the other states. I think New York also does it. But in places like Texas, undocumented patients, they're not even eligible for dialysis, and they end up dying very sadly because they jump from ER to ER. They get compassionate dialysis because the potassium is 9, they're dying, they just dialyze them and they send them out. So these guys go like 1 week without dialysis, they end up going into another hospital until something happens. And that's basically the life of those guys there. So a lot of the times we get a lot of these patients moving to California because they know or they hear or somebody advises them to come here, because here The minute that you become dialysis dependent, whether or not you have insurance, you will be covered. You know, taxpayers will pay for those patients, and based on this data, we know that transplanting these patients is more cost effective. Okay, so basically this is the annual end-stage renal disease cost per patient on hemodialysis, PD, transplant, and all stage renal disease. So we know that transplant patients are the less costly. You can see that, like, they get less hospitalized, they have less complications, they have more chances of having good quality of life, joining the workforce, and the mortality, the life expectancy is near normal. I wouldn't call it normal because transplant patients, they also die. You guys know what are the reasons why transplant patients die? You guys remember?
Any of like the attack, the graft versus host, or any of the hypersensitivity.
That's complications like rejection complications, infectious complications, but mostly they have an increased incidence of cardiovascular disease, transplant patients, and it's just the medications that we give them, like the cyclosporin and the prednisone. Those patients, if you weren't a diabetic, you're likely to become a diabetic when you get those meds, and they also develop, they have an increased incidence of cancer. You know what type of cancer in transplant patients? You know? Squamous cell carcinoma. So if for whatever reason you meet transplant patients, just always advise them to stay away from the sun, and always wear protective clothing, hats, like sunscreen, all that stuff.
Really? Interesting.
Yeah, the most common malignancy in the transplant population is the squamous cell cancer, and it can be incredibly invasive.
Is that because the medications they're on?
Especially Imuran, you know, azathioprine. That's one of the anti-proliferative agents that we use for, you know, rejection prophylaxis. That medication, like when you use it 15, 20 years, that significantly increases your chances. So always, if you want to give good advice to a transplant patient, if the doctor didn't do it, I don't think he's a good doctor, but you tell the patient, you know, stay away from the sun. You should all stay away from the sun, period. A transplant patient should stay away from the sun. That's the bottom line. Yeah. So, all right. So, options, we talked about this briefly. These are the access options. You know, we have a fistula, which is the ideal access. Then, for less ideal situation, we have the graft. Then you have the tunnel. Tunnel catheters cause infection, bleeding, thrombosis, and if you leave a catheter for a long time, there's a complication called central vein stenosis. Let's say that the catheter is sitting, you know, we almost always try to avoid the subclavian vessels because of central vein stenosis is very, very common in those patients. Like, if you were to image patients like 1 year after having a central line in the subclavian vein, 80 or 90% of those patients will have some narrowing. We call that central vein stenosis, and that can be very problematic for many reasons. Number one, patients can present with like one side of the face being swollen, or one side of the one arm being swollen, and more importantly, these patients, the access is the lifeline. And you can imagine if you have a young person, like I have an 18-year-old in dialysis, I have a 21-year-old in peritoneal dialysis. So those guys, you have to be very careful with how you handle the vascular access, because if you don't take care of them and you put a freaking catheter and you don't pay attention to those things, you're going to lose the whole arm, meaning that I won't be able to create any fistulas in this arm. Then you move to, usually you start with a non-dominant arm, then you have to move to the dominant arm, and when you know, these accesses, they have multiple complications. They make clot, they end up doing, the first fistula that vascular surgeons, they try to create is called a Semino fistula. Dr. Semino was an Italian surgeon that he described the technique many, many years ago. So the first one is they do basically, they do it with a radial artery right here. When they can't do it, they move here to the antecubital fossa, and then sometimes you see the patients with a fistula here. That means that the surgeon made a decision to do it here because there was no way of doing it here or here. I don't know where your guy has it. Is it here? Okay, so he has it on he had one here, so they started going 1, 2, 3, and then if this one, exactly, and this one fails, they need to move to his dominant arm, and that's more problematic because that's so. Like, the care of this patient include teaching them, do not let anybody take your blood pressure on the fistula arm. Do not let anybody do venipunctures on that arm because it can ruin the access. So, and again, the access is the lifeline of a dialysis patient. especially for young people. You want to protect that. You want to educate the patients like nobody should touch this. Like a lot of the time, I have like labor workers. Like I got a guy who's a mechanic, and this fistula is like full of aneurysms, and I get so nervous. This guy's gonna basically die from fixing something. Is gonna burst it, and people do die from these kind of complications like acute bleeding. Okay, so we have the non-tunnel hemodialysis catheter. You know which patients we use that? You know the difference between tunnel and non-tunnel, by the way? Okay, so if you're in the hospital, you're going through kidney failure, and we need dialysis today, we put a non-tunnel. That's called a Quinton. I don't know if you heard about like a Quinton. So the Quinton catheter is a non-tunnel. It's usually done at the bedside with an ultrasound. Easy to do. I do them in the IJ or in the femoral. Just put a catheter there, you dilate, you advance the guide wire, you put it in, you suture it, and you're done. Patients cannot go home with a non-tunnel because the non-tunnel is intended for inpatient use, and before you discharge the patients, they need to do a tunnel catheter. And the difference is that the tunnel usually is done by the surgeon or by the interventional radiologist. They use fluoroscopy, and they hide the catheter tract is hiding underneath the skin. That's what we call a tunnel. They create like a tunnel tract, and if you take a look at a dialysis patient with a catheter, you think that the catheter is going into the subclavian because most catheters, the exit side is usually in the chest. But if you take a look at the X-ray of these patients, the catheter usually is tunneled into the internal jugular vein, and that's the preferred side of access is the internal jugular vein. So it's hiding underneath the skin, going all the way to the internal jugular vein, all the way down to the right atrium, and the catheter tip sits right there, right above the right atrium. And that's another reason why you get so concerned about bacteremia, because the next organ that goes down is the heart. And a lot of these patients, I've seen many patients having bacterial endocarditis from a catheter and requiring like valvular surgery or dying from this. Okay, and the other option is the peritoneal dialysis catheter. So this is the vascular access numbers from the US RDS. Again, unfortunately, a lot of the patients are still getting initiated with a catheter, like over 60% of the patients in the United States. In my practice, we have a catheter prevalence of less than, in my dialysis unit, we have 170 patients. We only have 2 catheters. One is a lady who refuses. There's no way you can counsel her, despite everything, to get a catheter. To get a fistula, and the other patient is because he has a maturing fistula. So that's good medicine. That's basically, we're delivering very good nephrology because a lot of the complications for dialysis patients come from these lines.
What if you have a patient who's in the hospital and they need that they're not a dialysis patient already, but they need acute dialysis now? Are you still able to put a catheter in them, even if they're bacteremic?
If they're bacteremic, you cannot put a central, like a tunnel catheter.
So
it's
what do those
contraindicated.
patients
You
get?
put a Quinton. A non-tunnel. You put a Quinton and you try to take it out and you give them like holidays, like if they're really recurrently bacteremic. So it gets a little more tricky when patients have recurrent bacteremia. But if the patients have recurrent bacteremia, they have to investigate where this is coming from. Maybe the patient had undiagnosed bacterial endocarditis, or maybe has ascites or some sort of osteomyelitis. And especially MSSA and MRSA are very virulent organisms, and they metastasize to other places in the body. So again, ideal is fistula, and you can see here that fistula is probably less than 20% of the patients in the United States. So the best care is to have your patients have a fistula, and you refer the patients to get a fistula when the GFR is usually less than 20. Or I refer the patients to get a PD catheter. If they chose PD, I usually refer them when the GFR is less than 15. Why? Because the catheter, they can put it in. Like the surgeons that I work, they're pretty good, so they usually put the catheter within 2 weeks. Excuse me, and I only have to wait for another 2 weeks before I start using it. Whereas the fistula, once they do it, it takes about 6 to 8 weeks for the fistula to develop. And sometimes patients don't develop, and they have to have another surgery, either because it's too deep or they need to bring it up. We call that superficialization of the fistula. Or because there's some technical problem, there's something called Steele syndrome. So there's several complications related to this. So you need to plan ahead of time, and that's why the National Kidney Foundation recommends that we refer for access creation when the GFR is less than 20. Okay.
why is it that they don't remove old fistulas and just put new ones? I've seen someone with things all over.
Right. This is basically, we call this a defunct fistula. Probably it was functional at one point and it just clotted and they couldn't fix it. So then they moved to a more proximal location because there's so much they can do. There's only like 3 places where they can create access in the arm. So if you see several scars, that means that they started probably with this one, then they moved to this one, and then now they're with this one.
This individual I saw had like fistulas, and I could hear the rushing.
The thrill,
all of it.
Yeah. Sometimes there's like a venous stenosis, and they cannot use it, so they have to use the more proximal.
But they don't remove the old fistulas.
They don't remove them unless there is a problem. Like let's say the patient's getting you're getting an aneurysmal dilatation, or the patient has a graft, and the graft can get infected. If you're not using it, they just take it out. So, but there's no, like, for instance, when one of my patients get a transplant, they come and the first thing they tell me, I want to get these out. Why are you going to take it out? Oh, because I have a kidney. So what? You guys know what the life expectancy of a transplanted kidney is? You guys know? You think it's forever?
No.
How many years? 10 years. If it's a living donor, it can be up to 20 years or 15 to 20 years, but most disease donor kidney transplant, they only last for 10 years. And the first year is the most critical period because patients can get infectious complications or rejection complications. So if you do well in your first year, you're likely to continue to do well. But when the patients get all excited, they come in like, I want it out. Like, why do you want it out? Like, maybe if they're very strong about it, I refer them for resection, but I see it as a life insurance. You know what I mean? It's like you have life insurance there. If we need it, we need it. If it's not bothering you, we just leave it alone. And most patients do listen to the advice and just leave it there. Okay, so tunnel catheters, again, 80% of all patients initiate with a hemodialysis catheter. That's terrible. I'm actually very proud of our numbers because we don't want those numbers. So these are different catheters. They call it different. I don't know if you heard about Permanente. In some medical centers, we call them Tesios. But the correct technical terminology is a tunnel dialysis catheter. And this is the one that we use for outpatient or for patients that have a limited life expectancy. For instance, you have a patient with metastatic stage 4 or whatever cancer, and they still want to get dialyzed. I usually discourage patients with metastatic cancer to get dialysis, but if they have a good reason, I just want to see my son graduate or whatever, you just put a catheter and you dialyze them through, and they're going to probably not be here in 1 year. You use those catheters. Okay, so the right IJ side is preferred, and those are more like follow the tunnel hemodialysis, temporary access. Yeah, so the tunnel hemodialysis catheter. Like I was saying, palliative severe peripheral vascular disease, or patients with very low cardiac output, patients with like severe ischemic cardiomyopathy or some sort of cardiomyopathy. Those patients, they create the axis, and the axis clots. Why? Because they're very hypotensive, or because they just don't have enough cardiac output. In those patients, they end up failing the fistula, they end up with catheters, but it's always the less desired choice. Okay, disadvantages. Multiple studies have shown that they have threefold time mortality compared to patients that actually have a fistula or a graft, and the 1 year catheter survival is about 47.5. So a lot of these patients, they end up requiring like catheters to be replaced, and the central vein stenosis is a big deal. Okay, probability of bacteremia sepsis at 1 year is 27.5. Would you want to be walking around with something that can give you almost a 30% chance of becoming bacteremic? Yeah. So when I was teaching at all of you, a patient, she became very, very, very septic. She grew pseudomonas or something. I can't remember the organism. So when we asked her, like, why are you taking care of it? Like, I'm going to tell you the truth. We had a pool party. I couldn't take it anymore. I just dived into that pool, and I was swimming with a catheter. And he told me, like, I had the time of my life. Like, oh my gosh. But anyway, so you cannot wet it, and that's another inconvenience. Just imagine if you can't shower, you need to tell the patient you're going to sponge bath from your tummy up until your fistula is fully functional. Okay, fistula is the gold standard for vascular access. About 36%, only 36% had a fistula at the first outpatient hemodialysis treatment, and the Kaidoki goal is 65%. Our goal, where I work is actually much higher than that. So.
Okay. Is that just for the hemodialysis, the machine?
Only for
the patients with the peritoneal dialysis.
if they choose peritoneal dialysis, we don't do a fistula.
They don't need a catheter either. Or?
They need a catheter.
They just do the catheter.
They just have the catheter. That's the only dialysis access they have. But that's the beauty of educating them to make an educated decision. If you, let's say that you come to me, I'm following you through your whole disease, like stage 3, then you're progressing to stage 4, and then stage 5. I never had this conversation with you. That means that I suck, because I need to teach my patients. These are the options that you have. What do you want to do? And you'll be surprised. A lot of the patients, they tell me, I don't want any dialysis, even if I die, and they stick to their word and they die. So, but that's also a good decision for a lot of patients. They don't want it.
How long can you live without dialysis?
It's a very tricky question, and it's impossible to answer. If a doctor gives you an answer, he's lying for several reasons. Because I'm going to give you this example so you guys can think about it. Kidney does clearance and kidney does volume control. So the first thing that goes down is your clearance, your ability to clean urea, potassium, and all those things. But patients, they can still urinate. So let's say that your GFR is 5 mLs per minute. If you have 5 mLs per minute times how many minutes we have in a 24-hour period? 1440, right? 24 times 60, how much is that?
$1,440.
Okay, 1440, right? And then we're going to multiply this for 5 mLs per minute, that's the GFR. So you're filtering 7.2 liters of blood. You only need to reabsorb 5 liters, and then you have 2 liters of urine output. So the urine output is the last thing that goes. For as long as you have a urine output, you can live for a long time. Uremic patients can live for a long time because they're still making urine. They're gonna have very poor nutrition. They're gonna be confused. They're gonna have maybe they develop severe complications like uremic pericarditis or uremic bleed or severe electrolyte abnormalities. But if the patients are actually peeing, nobody can predict when they're going to die. If a patient is not peeing, let's say that you are a dialysis patient, you decided to quit dialysis and you make no urine whatsoever, that patient is going to be dead in less than 2 weeks because they have no urine output. But if somebody's urinating, they can keep going. In some Asian countries, they have something called intestinal dialysis. It's basically patients with stage 5 kidney disease, and they take a bunch of herbs, laxatives, so that helps with volume control in some degree of just imagine a liver patient that you're giving lactulose to get rid of the ammonia. So those patients, they can go for a long time, but obviously it's a very suboptimal way of being alive. You know what I mean? If you want to live, you need dialysis. That's it. But there is a, so to answer your question, nobody knows. But if they don't pee, for sure it's in 2 weeks. Just imagine if you're going to pulmonary edema. Okay, so
Is that what kills them? The pulmonary edema?
most of the time, or electrolyte. Like a lot of the times, patients that are non-compliant with potassium, they die during sleep, and they just have a hyperkalemic arrest. Hyperkalemia kills you within minutes, whereas hyperphosphatemia and the other electrolytes is more like a long-term type of thing. But hyperkalemia is a serious stuff. Okay, so the fiscal advantages, like I said, patients live longer, they do better, they have low maintenance. Sometimes we need to refer them to clean the fistula. We call that a fistulogram. I don't know if you heard about a fistulogram. So when the fistula clots, we need to refer them to vascular surgery. They just go in and they do a balloon angioplasty, or sometimes they use TPA to break the clot. And it's annoying for the patients, but at least they don't have to do surgery. It's just a procedure, outpatient procedure. So, okay, types of fistula, I don't think we need to know these. We don't need to know these. A graft, I already told you, is a piece of plastic. It's a large surface for cannulation. The advantages is it's less painful because the patients, they only feel like the skin, but they're actually poking into a piece of plastic. How long can it stay? I mean, the life of these things is not as good. They clot a lot and they require multiple procedures. That's why, and they get more infected. That's why you can't compare to the superiority of an EV fistula is way superior. And surgeons are usually hesitant. They prefer to actually do a fistula in other place than put in a graft because of the survival. It's not they have a lot more infection and pseudoaneurysm. And for patients with severe vascular problems, this is called a hero graft. You can see it's bypassing the whole brachial vein, and it goes into one of the central veins. That's usually done only by a few vascular surgeons. It's not ideal. One time I had a patient who was dialyzing on his tummy because he ran out of access. He has no access whatsoever. So the interventional radiologist put a tunnel catheter on his back going into the superior vena cava. Just to tell you how crazy. He had no access. Everything was clotted. Both arms, both neck veins. He had no access. And that guy basically, I don't know what happened to him, but that's a pretty serious situation. Okay, so the PD catheter, this is how it looks. It's basically, this is the external part, and there is a pigtail. It coils into the pelvic cavity, and basically that's how we deliver the solution. Usually it's placed laparoscopically. Usually it's done under general anesthesia, and usually it's done by either a vascular surgeon or interventional radiologist. They usually try to curve into the fascia, so there's not a lot of kinking of the catheter, and this is the correct position. It's in the pelvic floor. Okay, technical aspects. Okay, you guys know how dialysis works? Dialysis.
Some sort of bag with some small holes.
Mm-hmm. Filter.
Yeah.
We call that the kidney.
Yeah. Mm-hmm. And then there's a solution that you run through, and then you get extra.
How do you call that dialysis?
Dialysis.
So let's put it this way to put it simple. So you put you're a cook, and you have this solution with bicarbonate because that's what we need to give these patients. They can't reclaim bicarbonate because of the kidney disease, and you have to put a little bit of calcium, a little bit of potassium, and you put a little bit of sodium. I wouldn't say a little bit. You have to be isotonic here, otherwise you'll kill the patient. So sodium, calcium. There's usually no phosphorus because we want to get rid of phosphorus, but for some patients we do phosphorus. And then you run that into a countercurrent fashion. Like the blood isn't going in one direction and the dialysate is going in the opposite direction. So the guy who created it is a genius because he came up with two concepts that have been very well established and known is the fact that you move toxins from concentration gradients. So if I have no BUN on this side, on the dialysate, and you have a lot of BUN, things are going to move towards a less concentrated, like concentration gradient. Same thing happens with the creatinine, same thing happens with the other uremic toxins that we're not able to measure. And typically we call that diffusion. So that's the way dialysis works. So concentration gradient from one side to another. Okay, and the effectiveness is less efficient depending on the molecular weight of the molecule. BUN and creatinine, they're very small molecules, so that's why they remove very effectively. But proteins, they don't get removed because they're pretty large, like albumin and things like that. They don't go through these concentration gradients. And there is the other concept is convection. So convection is basically it's pressure is different in the pressure that you apply when you do ultrafiltration. I don't know if you heard about ultrafiltration. In the cardiac units, when the patients are very massively overloaded but they're not in kidney failure, they do ultrafiltration. They just basically expose the patient's blood in a filter towards a difference in hydrostatic pressure, and that way you're able to remove fluid. That type of transport is very inefficient for clearance, but it's very effective for removal of fluid. And that's when the patients come in like, oh, I'm 3 kilograms up, and the technician just puts 3 kilograms in the machine, and the machine does all sorts of changes in pressure to be able to remove fluid. Patients feel terrible when you ultrafiltrate and when you remove a lot of fluid. They start having cramps because all that fluid is being redistributed from the extracellular to the intracellular space, and they usually have a lot of symptoms when you do that. So the other type of transport is the peritoneal membrane. And the peritoneal membrane is actually very friendly from the hemodynamic perspective because everything is going in a very slow fashion. It's very slow. You're not exposing your patients to changes in the blood pressure. You're not exposing them to ultrafiltration. And usually when the patients are doing very poorly on hemo, that's actually the recommended modality is to switch them to peritoneal dialysis. Let's see, these are physiology from the peritoneal membrane, but I just want to move on to the other primary care stuff.
What does the procedure take?
Usually they get 5 exchanges. Most of the time, the standard prescription is about 5 exchanges with a dwell time of 2 hours. So, they infuse the fluid, like more fluid comes out in toxins, you get rid of that, then you infuse another 2 liters. It's about 10 liters. Some patients, they require a last fill. They go home, they go to work with a tummy full of fluid, and they drain it at work. And sometimes when they have no residual kidney function, these patients, they end up requiring a midday exchange. So it's more, it's not a good situation because you're pretty much doing dialysis the whole time. Bless you. Okay, so residual kidney function. Have you guys heard about residual kidney function? Is your dad pee?
What's my question?
What's that?
How much do these people on dialysis pee?
Well, invariably, most patients are going to become anuric. Completely anuric. And it depends on many reasons. We know for a fact that PD patients, they have better residual kidney function preservation at 2 years. But after 2 years, the rate of residual kidney function loss is pretty much the same.
So they pee like once a day or never? Or?
Sometimes they don't pee at all. Sometimes they have normal urine output. Those patients are very fortunate because this is the point that I'm trying to make. So if you're still peeing, you enjoy from more freedom from drinking more fluid. It's just obvious that you're not that limited. And the second thing is that these patients they end up having better phosphorus control because that means that they still have some nephrons that are doing some work. They enjoy from better blood pressure control because if they have some dietary indiscretion, they can handle it better than the completely anemic patient. But the reality is that the primary kidney disease is not going to stop because you started dialysis. So these patients, they end up, the diabetic nephropathy keeps progressing, or whatever GN they have, glomerulonephritis they have, it keeps progressing. And invariably, most patients become dialysis dependent. Also, when we put these patients on dialysis, we have to, let's say that the patients are not complying with fluid restriction. Yesterday we were discussing how important it is for dialysis patients to be restricted. But if they're not complying with fluid restriction, basically I have to use the ultrafiltration from the machine to remove all that fluid. Ultrafiltration damages residual kidney function. It's like you're causing ATM. It's like putting your kidneys on their stress test. Every time I do the ultrafiltration. In these patients, they generally do very poorly. I had a woman who was gaining 9 kilograms in between treatments. One time she gained 12 kilograms in between treatments. And I don't know if she was clearly trying to hurt herself or what was wrong with her, but she ended up dying from volume overload. Chronically overloaded patients, they develop a lot of LVH, and there's a well-described phenomenon in cardiology called myocardial stunning. And these patients, they have all sorts of like progression of left ventricular hypertrophy and increased risk of like cardiac sudden death and strokes. So we always want to counsel our patients, dialysis patients, to number one, protect residual kidney function. And when you guys are in practice, I want you to understand that if your patient is peeing, you have to protect that urine. And when you interview a dialysis patient, you want to ask, do you still urinate? And if they say yes, you better not prescribe anything that can hurt the kidneys, like NSAIDs. Sometimes some community practitioners say, oh, he's on dialysis, just give him some NSAIDs. It's not a good idea. NSAIDs are not a good idea for dialysis patients, period. Even if they don't urinate, because they can have a lot of gastric toxicities. But by the same token, let's say a patient goes in the ER and they need a contrast study. The question you need to ask yourself, if your patient is peeing, do I really need to do this? Let's say like they want to rule out PE. If they have a VQ scan available, why don't they do that? Because we want to protect the patient's residual kidney function. And many studies have shown that the patients with residual kidney function, they have a mortality benefit. So we want to protect these patients. So these are studies. I listed some of the studies that have shown consistently that patients with residual kidney function, they do better than patients without any residual kidney function. Okay. I listed the studies here, so it's a lot of information. Okay, so we know the ones in red that I listed, we know that there are actually, these are patients that usually lose their residual kidney function faster than other patients. Diabetes, I explained to you, diabetic is a progressive form of kidney disease, so these patients become anuric at one point. But also patients with comorbid conditions like CHF, they develop a lot of like cardiorenal syndrome and poorly controlled hypertension. Patients with extensive vascular disease, they lose residual kidney function fairly quickly. And some studies suggest the female lose it faster than males. And African Americans usually lose residual kidney function faster than other ethnicities. Sometimes, like, there's some studies saying that increased calcium level protects residual kidney function, but we don't give calcium to our dialysis patients. It's actually contraindicated. Okay. So, okay, other factors, you know, if your patient has like obese patients, those patients they don't do well. And initiation of dialysis after renal transplant failure. Okay, so this is basically mechanistic framework. Increased cardiovascular risk, as if you look at the morbidity and mortality from chronic kidney disease patients, you very soon you'll realize that you're 20 times more likely to die from cardiovascular complications when you have kidney disease than from kidney complications. That's why we have to be so aggressive with like cholesterol goals, blood pressure goals, like cardiovascular prevention. So these patients with residual kidney function, they have suboptimal water and sodium removal. They have basically peritoneal versus renal fluid. Okay, so basically what it comes down is that the cardiovascular effects of not having kidney function, I listed them here. They have suboptimal blood pressure control. They have more LVH. They have more vascular calcification. They have more inflammation and more cardiovascular calcifications. And these are markers of cardiovascular risk. The serum phenytoin A level is much higher in patients without residual kidney function. So there's a lot of science behind this. And that's why in primary care we have to make every effort to preserve residual kidney function. That's another thing, like patients that they still have residual kidney function, they have better nutrition. And in peritoneal dialysis patients that they don't pee, they have a higher risk of developing PV peritonitis than patients that still pee. It's incredible. This is like a busy slide, but it just shows the same thing. More malnutrition, more cardiac hypertrophy, more atherosclerosis, and more vascular and valvular disease, and less quality of life and less survival. That's the bottom line. Okay, so factors that can protect residual kidney function. So if a patient urinates, I give him Lasix. Why? Because the fluid that you pee is the fluid that I don't have to take out with my machine. Therefore, I'm protecting your kidneys. If your patient is a diabetic, you give him an ACE inhibitor. Why? Because you're protecting residual kidney function. It's funny, they always make fun of the nephrologists because we start ACE inhibitors to protect kidneys. As the kidney function gets worse, we have to take them off because they become hyperkalemic. And then when they become dialysis dependent, we give it back to them. And why? Because we want to protect residual kidney function. And yeah, let me see. So loop diuretics and ACE-ARB are ways of protecting residual kidney function. Contrast studies, like I said, if you can avoid it, just go ahead and avoid it. Aminoglycosides can be nephrotoxic, so if the patient urinates, just think about it twice. And if your patient has a transplant and the transplant is failing, you don't stop the immunosuppression because you became dialysis dependent. Or if the patient still urinates, you're supposed to continue immunosuppression for as long as the patient urinates. And once they stop urinating, you have to gradually take off these medications. You probably start with Celcept, and then you move on to go down on the calcineurin inhibitor, and the last thing to go away is the prednisone, and you have to do it at a very, very slow taper, like 1 milligram per 3 months, and then you can keep going. If you stop abruptly medications, patients can have acute rejection. Patients can really have, they can get very sick, and it's just not a good practice. So you have to do it in a very slow fashion. Okay. So frequent hemodialysis, I was mentioning to you guys that these patients, they do very well. So the more dialysis is better. Like my typical dialysis prescription for all of my patients is no less than 4 hours, and I do it 4 hours 3 times a week. And the more dialysis is better blood pressure control, better clearance, and better survival. There's a lot of like things that are not tangible. Like for instance, like under dialyzed patients, sometimes the patients they try to be smart and they start telling you, you know what, I want to dialyze less, you know, I'm sick of this, and I don't blame them. You know, if you go to a dialysis unit, it's not a happy place. But you need to explain them from like I was telling you guys yesterday, education is the most important thing you can do to your patients. You need to explain it that there's a lot of non-tangible things. Like for instance, patients that get under dialyzed, they bleed more. They have GI bleeds out of the blue. You know, you guys have heard about uremic bleed. These guys bleed for whatever reason, they have a GI bleed or whatever. They get more pneumonia, they get more hospitalizations. And those are things that I cannot measure, like saying, oh, it's because you're not getting good dialysis. But many studies suggest that more dialysis is better for the patients. But the problem is to convince the patients that they actually need more dialysis. Okay, management of hypertension, I already told you guys yesterday. You probe the weight, you challenge the dry 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 weight, and if it doesn't work or the patient is unable to tolerate it, then you start playing with medications. Remember we talked about that yesterday? Okay, very good. We already talked about this. Okay, patients with intradialytic hypotension. This is a challenging group of patients. It's very common in the dialysis population. Sometimes they pass out during dialysis, and it's a very scary situation for the nurses because they can't do anything in the dialysis unit. They don't have a crash cart. They cannot give medications. They cannot transfuse patients. They cannot even do an EKG in a dialysis unit. So whenever they need assistance, they have to call 911 and they come and they assist these patients. So, but typically patients with intradialytic hypotension are patients that are, number one, not adherent to fluid restriction. So they drink 5 liters and they tell the nurse, hey, try to take out 5 liters. Obviously, that's not smart, and the nurses shouldn't be doing that. The nurses know that anything beyond 4 liters is not safe. Sometimes the patients insist that they want to have 5 liters, but like I always tell them, if you want to do it on your own, don't put that you talk to me about this. It's up to you because you know that 4 kilograms you're already pushing it to the limit. But sometimes some nurses it's like a competition between them. Hey, you know what? I pulled 6 liters from this guy. The technicians are very proud talking between them, like, oh, they did 6 liters. Like, you know what? I don't want to hear about it. Don't ask, don't tell, like kind of thing. Like it's not safe. You know, if you're doing this to the patient, it's not safe. Next time, so they learn the lesson. You need to tell them the doctor wants you to do 4 times a week dialysis, and maybe they will listen. Maybe they'll start cutting down on the fluid intake, and because it's inconvenient to be 4 times a week on a dialysis machine. But we also have the patients that have severe autonomic dysfunction, typically the diabetic with peripheral neuropathy, or the patients that have severe cardiomyopathy. Those patients become very challenging to dialyze because of hypertension. So some of the strategies we do is we tell them, number one, don't eat during dialysis because that will make you hypotensive. Number 2, we lower the dialysis temperature because it causes peripheral vasoconstriction, therefore makes you less likely to become hypotensive. Some doctors prescribe midodrine and some of these medications to bring blood pressure up. I don't think that's a good idea. In fact, there is no good quality study showing that that's an effective strategy. So the most important thing is to educate the patient. Number one, you can gain so much weight in between treatments. And number 2, lowering the dialysis temperature is very effective. For those patients that you do everything and nothing works, those patients benefit from doing peritoneal dialysis because I already explained to you guys that these patients, they tend to have less hemodynamic fluctuations during the treatment because the transport happens in a very slow fashion and there's really no hemodynamics involved. Okay, so this lipidemia management in end-stage renal disease, there was a trial called the Aurora trial and the Sharp trials. They said that there is no use of using statins in dialysis patients. I question the data from these studies, and I honestly think that we have so much data on the effectiveness of these medications. This is before your lifetime, probably, like when I was in med school in the 1990s. Cardiovascular mortality was so high. And at that point, we started using statins, and we started using beta blockers and ACE inhibitors, and now we see that our cardiac patients are living longer and longer, and you don't see them dying as frequently as before. So to me, like, like I used the data from these studies with a grain of salt. They said do not start the patients, but what they do say is that if your patients were already on statins, you need to continue them, even if they become dialysis dependent. The bottom line is that, you know, the cholesterol guidelines, they keep changing. I don't know if you guys heard, last year they released new cholesterol guidelines. Honestly, I became even more confused after I reviewed these cholesterol guidelines than I was before. But what I use is just common sense and judgment. And remember this, kidney disease patients are 20 times more likely to die from heart complications than dying from kidney complications. That summarizes everything. To me, it's like no point of negotiating. I just give a statin. That's it. Smoking in dialysis patient is horrible. These patients have a really serious mortality from complications, and we all know that smoking is no good. But smoking and being a dialysis dependent patient, you should be buying an insurance plan to pay for your burial expenses. Okay, sudden cardiac death and congestive heart failure. It happens a lot. Like we lose patients, you know, and said, oh, Dr. Lopez, this patient, you know, he passed away. We don't know what happened. Most of the times, it's because of hyperkalemia. Like I explained to you guys, hyperkalemia can happen very suddenly. If you have no residual kidney function, you're totally dependent on dialysis. So the nephrologists, we have several ways of approaching this problem. Number one, we have to make sure that this is not an issue related with poor clearance, because there's a complication called recirculation syndrome. Basically, you're cleaning the same blood over and over because the patient has some degree of stenosis, proximal stenosis. But we're able to catch those patients because there's some markers of adequacy of dialysis, and we hope for some minimum number. If the patients are having like a low number, we kind of suspect that there may be a problem related to the axis, and we refer those patients to get an angioplasty of the fistula. So that's number one. Number two is that we can control the amount of potassium that the patients get on the dialysate. In some countries, like in Korea, they use a zero dialysate bath for patients that are recurrently hyperkalemic. We don't do that here. It's too dangerous. You know, you don't want to dialyze a patient against a zero potassium bath because hypokalemia is as dangerous as hyperkalemia. And in fact, we know that patients that get dialyzed with a 1K potassium bath, they have a higher incidence of cardiac sudden death. Maybe because they become hypokalemic, or maybe because they're so non-compliant with the diet and the potassium is so high that these patients end up dying from complications related to hyperkalemia. But if you see a patient on a 1K, I don't know if your dad is on a 1K, did they tell you?
No, we tried to put him on low dialysis potassium, but they are not. They didn't.
Doctor didn't want. He's taking good care of your dad. You know, I mean, sometimes they put him on 1K, and the patient said, like, you know what, I'm going to eat whatever, and I'm going to stay on 1K. But he's basing his decision on studies showing that patients that remain on a 1K, they die, and it's just not safe. I mean, it sounds like to me, we haven't talked in depth about your dad, but it sounds to me like he's not compliant with potassium restriction.
No, he eats everything.
He eats everything.
Especially bananas.
So, yeah. So, you know, unfortunately, it's a serious, non-compliance is a serious disease. It's a lethal disease, especially in nephrology. And there's so much you can do. So the guy said, you know what, he can't do PD because PD patients, they actually have the opposite problem. They become hypokalemic. They lose potassium in the exchanges. So these patients require some kind of like supplements. But anyway, so that's the way we approach hyperkalemia, and it's a serious disease because if your dad is not listening, I mean, there's really nothing we can do.
He drops like to 5.4, 5.8.
His potassium
Yeah.
is still high.
It's still high.
And what's his highest?
6.
That's not good.
6 is the highest.
He's not scared about that, or?
No, he's cool about it. I am scared. He's like, the problem now is the hypertension, the intradialytic hypertension.
Yeah. And patients with a 1K, they develop more intradialytic hypertension too. Yeah. And then how many kilograms does he gain in between?
No, he doesn't gain a lot, like 1 kilo or something. It's just, he keeps dropping.
Just tell him to lower the temperature, the dialytic temperature. That would help a lot. Okay, so CHF, these patients, they get hospitalized a lot for CHF. Why? Because I told you guys yesterday, the weight, there's two concepts that we teach patients. Dry weight and your water weight. Your dry weight is where your body, your blood pressure is happy, you're happy, and everything's stable. The water weight is what you gain in between treatments. The recommendation is no more than 1 kilo per day. So during the week, 2 kilograms. During the weekend, 3 kilograms. Some patients don't listen, like I said. Those patients, they suffer the most, the complications from dialysis. But in the winter months, patients for the holidays and everything, they start eating more. So I need to adjust the weight because they're gaining solid weight. But in the summer, sometimes they end up losing weight. So you have to bring the weight down. Otherwise, the patient is going to end up getting admitted with congestive heart failure. So it's a little tricky. It's a very dynamic thing. How do we know things are changing? The patient always knows first if the patient is cognizant and aware of what's going on. And the second thing is we have to look at the blood pressure. If the blood pressure is too low, that means that the weight needs to be raised, unless the patient has a history of congestive heart failure. Because if you raise the weight, you know that the patient is going to end up getting admitted with CHF. If the blood pressure is too high, you know that you need to bring down the estimated dry weight, because that means that the patient is losing weight. So it's a little tricky, but you get used to it after doing this for a while. Okay, ischemic heart disease is common. It's about, patients on both modalities, hemo or PD, they develop this complication. I already told you guys that it's quite common, quite prevalent heart disease in kidney disease patients. Same as peripheral artery disease. Anemia, you guys heard about EPO? Okay, EPO accounts for 50% of the cost of end-stage kidney disease in the United States. So Amgen was a garage company in the 1980s when they invented this molecule. They became like one of the top 10 Fortune 500 companies in the world. It's a very expensive medication. They've done a series of changes in the legislation of end-stage kidney disease care, like from the political changes. In 2010, the U.S. Congress passed a law called the Bundles of Care. Before this new law was in place, doctors were able to bill for everything. So a lot of the doctors were giving EPO for everything. They were just like giving EPO to normalize hemoglobin, or they were giving EPO for critically ill patients. And Amgen was so happy, like trying to find more and more indications for EPO. It turned out that very clear, very well-made studies show that if you correct the hemoglobin to a normal value, you're doing a disservice to your patients, because these patients, they end up dying from thrombotic and CVA complications. So we now know for a fact that we want to keep our end-stage kidney disease between a hemoglobin target of 10 to 12. And after the Congress passed that law, it's amazing how the practices started transforming, because the new law basically tells you, I'm going to pay you this much to take care of this dialysis patient, and you figure it out how you're going to save money. So what the doctors and the owners of dialysis units, they ended up giving more iron, and they realized that iron is as effective as EPO to correct anemia, and now we're using less and less EPO as a result of that legislation. So it's amazing how a change in compensation and reimbursement completely transformed the way we practice nephrology in the last 5 years. EPO is a growth hormone, so we don't use it for patients with active malignancies, and the other contraindication is patients with severe hypertension. Yesterday we were talking about drugs causing hypertension. EPO is one of them. You know who Lawrence Armstrong is?
Yeah.
He's the EPO champion. Like, I use it a lot. And okay, so this is the study basically that concluded that normalizing hemoglobin was dangerous, detrimental for patients. Okay, so markers of iron deficiency. So we look at the ferritin. If the ferritin is less than 200, we call that iron deficiency. And also if the percentage of transferrin saturation is less than 30, we call that iron deficiency. So nowadays, like I was just mentioning, we're pushing a lot of iron, IV iron in these patients. Okay, management of diabetes. Mellitus, have you heard about, like, doctor, my diabetes is cured? I get these all the time with patients coming in with progressive kidney disease. Like, doctor, my diabetes is cured. Like, no, dude, your kidneys are gone. That's basically what's going on. So the way it happens is that you still have endogenous insulin production, and that insulin is not cleared by your kidneys because your kidneys are just getting worse. So a lot of times patients get very excited. And I tell them like, no, this is not the case. And in fact, when you get a kidney transplant, your diabetes is going to go nuts for multiple reasons. Number one, because you're going to have a normal functioning kidney. And number two, you're going to get high dose steroids, and you're going to get the calcineurin inhibitors. Those medications cause a lot of insulin resistance. So these patients get pretty sad when you tell them those things. But diabetes doesn't get cured. It's just a change in the insulin requirements. So you got to be very careful with these patients because the incidence of hypoglycemia is pretty high. Before I came, my last patient. I had to switch one of the sulfonylureas. It's called libride or glimepiride. Have you guys heard about glimepiride? We try to avoid glimepiride in advanced kidney disease because it's longer acting. So the way I remember, for you guys to remember, glipizide is a shorter word than glimepiride. So glimepiride is longer acting, and the best medication for these patients is glipizide. And you guys remember that we cannot use metformin in the setting of advanced kidney disease because it can cause fatal lactic acidosis, and it's a medication that is contraindicated in advanced kidney disease. So a lot of times you have to be very careful with insulin dosing and things like that because, again, it's cleared by the kidneys. If the kidneys are not working, you can cause significant hypoglycemia. Okay. So potassium, daddy. So common and potentially life-threatening disorder among dialysis patients, and it can cause paralysis of cardiac arrest. All the spectrum of EKG abnormalities, including from the white complex, ventricular rhythm, and ultimately systole. I don't know if you've seen the severely hyperkalemic EKG. It's actually pretty scary to look at that. So, but the EKG is no sensitive and is not specific in detecting hyperkalemia. And another thing that your dad should be aware of is to fight constipation. Why? Because 90% of the potassium handling happens in the kidney. But I was just telling you guys about these countries where they use like intestinal dialysis. There is some truth to it because the gut kind of adapts to help the kidney in some ways, and so there is some handling of potassium by the gut. So if your dialysis patient is recurrently hyperkalemic, make sure that they're not constipated because constipation can cause worsening hyperkalemia in these patients. Okay, pregnancy in dialysis patients. Can you get pregnant if you're on dialysis? I mean, they have a lot of infertility because they have like messed up ovulation and things like that, but they do get pregnant, and it's quite challenging for the nephrologist and for the patient because you constantly need to be playing with the weight. She's gaining solid weight, and yet you don't want to be like behind because if you don't adjust the weight, you're potentially hurting the mom and the baby. So it's quite challenging for these patients. Usually we increase the frequency of dialysis because the clearance requirements are increased. These ladies that I have never had the honor of taking care of a pregnant lady, but my attendants did, and they've always told me that it was very challenging to keep up with the weight adjustments, and also there's an increased incidence of low weight at birth and intrauterine growth retardation. But my attending she published 5 patients. She's one of my UCLA attendings. She had 5 patients that were pregnant, and she was successfully able to carry through the pregnancy. So the best scenario you can advise your patients is go ahead and get a transplant in 1 year. If everything goes okay in your first year, you can go ahead and get transplanted. We have to make some adjustments in your transplant medicines because pregnant patients cannot be in CellCept, but it's still feasible and possible, and they have much better outcomes if they get pregnant after they get a kidney transplant. So that's usually the advice that I give to patients, but it's hard to give that advice to someone who has no living donors. You guys know what the wait time for a transplant in California is? 10 years.
What?
If you don't have a living donor, you're going to be on dialysis for 10 years. So unless you have hepatitis C, because hep C donors are more frequent, because they have riskier lifestyles, so they die more frequently, and they donate. Or you have HIV also, because they can only give you an HIV positive kidney if you're HIV positive. But if you're a normal citizen paying your taxes, waiting in line, you have to wait for 10 years. Even if your name is Barack Obama, you have to wait for 10 years.
What if you can't ask for a hep C kidney?
If you don't have hep C,
Yeah.
it's unethical. They would never give it to you. No,
You can. It's also like.
they won't give it to you. So UCLA program.
When you say a living donor, is that like somebody you find yourself?
Somebody you find yourself, or somebody or family member. Before there was a contraindication for ADO incompatibility. Now it's less of a problem, less of a concern, because they have augmented immunosuppression protocols where they give in more immunosuppression or they do plasma exchange before the transplant, and they're still able to transplant ADO incompatible patients. Let's say that you have your partner, and then like this person really has a strong feeling about your kidney going to you. They do that, but it's not ideal. For the ideal scenario is to participate in a very successful program that UCLA has been pioneering over the last 10 years. It's called the Pair Exchange Program. Have you heard about that? Okay, so the Pair Exchange Program is, let's say you want to give me your kidney, and we're not genetically compatible, and you're cool with your kidney going to somebody else. In return, I'll get a more genetically compatible kidney, and everybody goes to the OR at the same surgical time. So they ship kidneys from Cornell, from the East Coast. They swap these kidneys.
Wow.
It's a very successful program. Yeah, they do that, and they've been able to help.
And one is enough?
One kidney is enough.
What's the risk for the patient giving their kidneys?
It's a slight risk of developing dialysis, like down the road.
Yeah.
Very, very minimally, slightly increased compared to the general population. But research shows that patients that donate, they tend to be more aware of their health, and they tend to have more like healthier lifestyle. And then it's actually, there is a big debate right now because in the U.S. you cannot buy a kidney and the donor cannot be compensated in any way. In some countries, they've been doing this for years. They actually get paid, and you would think it's just reasonable to do that because once they donate a kidney, you're gonna have issues with life insurance, like buying life insurance or buying like disability insurance. So it's unfair to these donors that they're giving life and yet they're being punished from doing that. So, but I think we're gonna get to a point that the donors are gonna be compensated in some way. But the laws in the U.S. are very strict in that regard because the donor has a team of healthcare professionals advocating for the donor, and it's a completely separate team from the recipient. And they do that because they want to make sure that there is no conflict of interest. There's no, like compensation or benefit or secondary gain from donating. And they want to make sure that you understand the reason why you're donating. Let's say that you find a donor, and they interview that person, and they sense that this guy's gonna get paid, or maybe he's donated a kidney because he's in love with her and she's not paying attention, and he's expecting that this is gonna get to whatever he wants from her. They immediately they tell him you're not a good donor. So they have very strict guidelines and completely separate teams. The recipient and the donor have a completely separate team. In the Philippines, you can buy a kidney. In Iran, you can buy a kidney. In the U.S., and then in the Philippines, it's available only for Filipino nationals, for no one else. And in the U.S., you have to wait online. The other thing that people with money do is that they register at different transplant centers if they have money, and that's what Steve Jobs did. He needed a liver, and he registered somewhere in the Midwest. The liver became available. He flew on his private plane. He got his liver. He only waited like less than a year. But the wait time, let's say for a kidney in Utah, is only 3 years. In Oregon, is only 3 years. One of my patients is seeking transplantation in University of Minnesota or something like. No, it's not even Minnesota. It's like a rural Midwest state. The wait time is 9 months.
Wow.
And that Kaiser doesn't pay for it. She's gonna have to pay it out of pocket, and she's willing to do that.
Kaiser won't pay for transplants?
No, because it's not part of the. It's not a benefit covered in the health plan. The health plan is offering a kidney, where you're paying for your health plan in California. But it's too bad that the wait time is 10 years. It's like just think about going for dinner Saturday night in LA. It's the same thing. There's too many of us. So it's unfortunate for patients waiting for kidney transplant. But the best thing you can do is to get a kidney, to get a kidney like a living donor. Okay, so sleep disorders. These patients, they have a terrible sleep disorders. One of the patients is telling me today in clinic, I can't sleep. And part of it is because of uremic toxins. Part of it is because they nap during dialysis, which is a mistake. If you're having trouble sleeping at night, the last thing you need is to nap during imagine if you're bored to death in a dialysis unit, what else do you do? Sleep, right? So these patients, they have a lot of issues with their sleep. They do have one of the things that helps these patients is usually like discussing the sleep hygiene, like go to bed only when you're tired. The bed is only to sleep. Try to stay away from like television or like electronic devices. Avoid napping, avoid caffeine, avoid drinking fluid if they still pee, because if they drink fluid at night, they're going to wake up to urinate. So all of those things, if they have pain, you need to approach the patient from that perspective. And generally speaking, we stay away from sleeping medications on these patients because they have significant side effects, and you're doing a disservice to your patient. If you start managing every patient with insomnia with medications, you're doing a terrible thing to your patients, because especially if you have elderly patients, if you're doing geriatrics, you're going to realize that's a big no-no, like capital N, no-no. Don't give these medications to elderly. Okay, mental health, I already told you guys, the depression is the increasing incidence of depression, but it's mostly adjustment. They kind of feel like the end is coming because they read about these statistics that I'm going to be dead in 10 years, and they hear about it from other people. They look around and they see people like looking so old. I'm telling you, I've been with this dialysis unit for 3 years, and every time I go, my patients are aging so much, like physically. You look at them and like, wow, this guy's looking a lot of street miles. It's very sad for them because they have a lot of vascular aging from the phosphorus and the calcium deposition in the arteries, but they also have like an accelerated aging. So a lot of the times these patients, they look around or they drop dead and they don't see their friends anymore, and they ask around, and obviously there's always a nurse that breached confidentiality, and like, oh yeah, he died, and then they get pretty depressed about like not knowing where the friend was. So a lot of these things factor in, but there is also an increased incidence of personality disorder in this population. But again, it's not because the dialysis make them crazy, it's just because they're not compliant and they end up on dialysis, and they're likely to continue with the same behaviors in the dialysis unit. Okay, pain controlling dialysis patients. So you do not want to use meperidine. Demerol is extremely contraindicated. If you give it to a patient, he's going to have a seizure and it's going to be on you. Also, tramadol is contraindicated because it also builds up and it can cause seizures as well. And a lot of the narcotics, long-term narcotics, are not a good idea in dialysis patients. If you were to use narcotics, there's 2 narcotics of choice in dialysis patients. One is called methadone. But methadone, you need to have an EKG, and you need to prescribe it to patients that are not alcoholics. And also fentanyl is the other narcotic that we use for this population. Things like Norco, Percocet, you name it, those actually build up, and there's a metabolite that can actually cause a lot of confusion and alter mental status. So the bottom line, if you use Norco for a few days, fine, but if you're planning on managing chronic pain with Norco in a dialysis patient, it's not a good idea. It's something that you don't want to do. Osteoporosis in end-stage kidney disease, it's tricky. The only way to diagnose osteoporosis is by doing a bone biopsy. It's not practical, and I haven't done it in my practice because I don't even know a good bone pathologist to be able to diagnose. There's different spectrums of bone mineral disease in dialysis patients. You can have anywhere from adynamic bone disease. Adynamic bone disease is basically the patients that they don't have any turnover, so they have very, very brittle bones. Or you can have the other spectrum of the disease. It's called osteitis cystica, or you can also have osteoporosis. So the bottom line is that you don't screen for osteoporosis in these patients. Why? Because number one, the DEXA scan is not specific to diagnose the right spectrum of disease. And number two, most of the osteoporosis medications are contraindicated in these patients. Fosamax, alendronate, all these biphosphonates, we cannot use when the GFR is less than 30. So the best thing you can do for your patient for bone health is make sure that the PTH, the parathyroid hormone targets, are within goal. Make sure that you're giving them vitamin D, and we don't give them calcium because we know that dialysis patients with a positive calcium balance, they have an increased incidence of calcification, valvular calcification, and cardiovascular complications. Okay, access preservation, I already told you. The Dialysis is the lifeline of your patients. Immunizations in patients with end-stage kidney disease. Make sure you give them all. That's all I can say. You know, the flu saves lives. The flu shot. You have to be very strong with your patients every day in clinic. Today I vaccinated everyone, but one patient was giving me a hard time. I told him, like, you get the flu, you're gonna end up on dialysis. Immediately he got scared. He got the vaccine. And I don't mean it to scare him, but I mean it to educate patients, because if you have stage 4 kidney disease and you get the flu, chances are you're going to become dialysis dependent. But for our patient dialysis population, it's very important that we dialyze everyone. As of 2014, the FDA approved a new vaccine. It's called Prevnar 13. Have you guys heard about Prevnar 13? So Prevnar 13 is it's a new pneumococcal vaccine with 13 different polysaccharides. And this doesn't replace Pneumovax. It's in addition to Pneumovax. You know, there's some guidelines for interval administration, but make sure that your dialysis patients they all get this vaccine.
Even the Pneumovax even if they're under age 60.
They need to get it. Yeah. Everybody with dialysis they need to get all these vaccines. Okay, coordination of care. So, like I told you guys, if your patient is hypertensive, the best way to help your patient is to communicate with the nephrologist, because you don't manage these patients with medication, you manage them with more dialysis or more ultrafiltration. And there is a lot of fragmentation of care in the community. You're experiencing that because the nephrologist doesn't know a lot of the things that are happening with the other doctors. In my system, it's a closed system, so there's no such a thing as fragmentation of care. But fragmentation of care is a deadly disease. You know, doctors can end up doing procedures that they're not indicated, or they don't know what's going on, and coordination of care is very important. So if you have a dialysis patient, usually the nurses know the patient the best, even better than the nephrologist, to be honest with you.
I try to do that.
Yeah.
Train doctors.
Exactly, it's not good. Okay, so routine labs are no longer part of dialysis units. Okay, and lastly, you guys need to advocate to help your patients to get a transplant, and do not let them give up. I have young patients telling me like, oh, you know what, I wanna stay on dialysis, and they're in their 30s. That's a mistake. You know, if your guy is a young person, he should get a kidney transplant.
He's over
82.
80.
Okay, so he won't be able to get a kidney transplant. But anyway, so and the other message for you guys is protect residual kidney function. It's very important. Okay. I think that's it.
I have a question.
Yeah.
I have two questions. One is quick. So we were talking about today, what if your patient's a cardiac patient and taking aspirin every day? Is that also contraindicated for kidney patients?
Excellent question. That's for like the low dose aspirin.
Yeah,
Not
maybe
associated with analgesia.
Okay, that's fine. And the second question is, for patients with dementia and renal failure, do they go on dialysis? It sounds like you need to have good.
Depends on your. It depends on your nephrologist.
Uh-huh.
My mother died from Alzheimer's,
Mhm.
and there's no way in the world I would have put her on dialysis. There's no way. So, I think if you're ethical and if you're compassionate about a person with dementia, you let them go,
Okay.
because dying from uremia is actually it's an easy way. It's not painful. Patients don't suffer. They die in peace,
Okay.
like when you die from kidney failure. So, but you see everything. There's a dialysis unit in Sherman where it's the only facility doing patients on the ventilator.
What?
It's the only facility doing vented patients that they get bedside dialysis or chairside dialysis. They need to transport these patients from the nursing home with an RT, a nurse and an RT, to get dialysis 3 times a week. And a lot of these patients, they don't even have code discussions like end of life care, like advanced health directive. And maybe I'm heavily biased because of my personal experience with my mother, but I honestly think that in this kind of situation we should not do any invasive treatments, and I always seek consent for the patients and not from the family. And when I'm stuck in a situation where I have to seek consent from the families, I try to persuade them away from doing this, because dialysis is supportive therapy. It doesn't improve any outcome. Like even when they call me from the ICU in a patient that is like a train wreck, I always tell the families this is not gonna change prognosis. This is just a supportive intervention. We're helping the patient to be able to see if they can pull through or if they can take care of whatever their main problem is. But dialysis is just a manifestation of the multi-organ failure. And it's the same thing, like long-term dialysis. I think patients with terminal malignancies, unless they have like a very clear thing, like what I told you, like I want to see my son graduate this summer, let's do it. But a patient with like really bad like functional status, like you try to persuade them away. So that's why I have a very good relationship with palliative care doctors, and I get them involved very early. When I see there is a conflict situation coming up, I usually get the palliative team involved, and they're very good because that's all they do. They get trained to explain and to present things in perspective to the families, and a lot of times patients say do everything because they're afraid or they haven't been educated enough by the doctors about what's coming up. If you've seen a survivor of cardiac arrest, like with a feeding tube, dialysis, a trach, and a ventilator, and an oxygen brain injury, I don't think you would want to have any of these things for you or your loved ones. I mean, it's just that simple. And there is actually research showing that we, people in healthcare, were less likely to accept like aggressive end-of-life treatment because we've seen enough. And we know that once you reach that stage, we're done. Like there's no purpose of being alive.
Yeah, I read a really good article on that called How Doctors Die.
Yeah.
I don't know. Can we talk about that?
Yeah. How doctors die.
How Doctors Die. Yeah, you guys should Google it.
Yeah.
It's really good.
Yeah. Yeah. Most of us we decided not to have like any of these aggressive because there's no
That's
point.
what I want to do.
Yeah.
Care. Do like palliative care
Palliative care is good.
with old patients.
Yeah. It's a great field and then plenty of jobs.
I want to do geriatrics and like focus on like hospice and quality of life.
You'll have plenty of jobs